Phases of treatment. Okay, very, very important. And this has been in numerous practice guidelines. Okay, this is not derived from any specific study, but it's a part of the APA guidelines. Phase of treatment. Acute phase is until a person says, "Hey, I'm not depressed anymore. Thank you very much." Better living through chemistry. And the problem here is that when a person gets to that place where they're saying, "You know what, I think I'm okay. I'm out of this depression, thank goodness." If you stop at that point, then within 4 weeks, at least 50% of people will crash right back down into the depression. It may be as high as 80%, but most studies show at least 50%. Now, what this suggests is that somehow something's been normalized neurochemically in the brain, but it's not stable. The metaphor that I use with some of my patients is if you were building a concrete step and you put boards in there and you poured concrete in it, but you took the boards away too quickly, it would collapse. So you need to have, the support there for longer, and then it becomes stabilized. Okay, so most people then need to enter a continuation phase, and continuation phase begins at the point where they say, "I'm okay." Now, this may be really counterintuitive for people because, like, why should I take this drug? It's giving me some side effects, costs money, I feel okay. But what's been shown is that if you discontinue prematurely, high rates of relapse. Also, there is, and I don't know where this comes from, but there's this myth in primary care mainly that once you're asymptomatic, you can lower the dose to reduce side effects, but it doesn't work. Okay, you get lots of recurrence. Actually, it's referred to as acute relapses. So it's at the same dose. And then finally is maintenance treatment. And with maintenance treatment, this is where the person stays on the medicine for maybe for the rest of their life. And this typically occurs if it's their third episode. Now, there are people who don't understand about depression or they're very opposed to drugs who say, "Oh God, that sounds horrible. You have to stay on this for the rest of your life. Is this a conspiracy of the drug companies to make money or what have you?" But I'm going to tell you something. In many, many years of treating people they're in the third or fourth episode, I have never have to talk somebody into staying on the medicine. Just the opposite. People say, "For God's sakes, don't take me off this medicine." Because they and their family have been through absolute hell 3 times. Okay? Now, this is not perfect because things change. Your body changes, brain changes, metabolism changes, new life stressors. People can have breakthrough episodes, but it's not a bad hedge to prevent reoccurrence. Okay, antidepressant discontinuation symptoms. Now, this is a big deal because if you've been on for months and you stop cold turkey, you feel really sick. And basically, people feel like they have the flu, nausea, GI upset, and real achy, your joints achy. And there's this weird thing that people say, "I feel like electric shocks are going through my arms or through my brain." And I remember maybe 10 years ago when it started getting reported in psychopharmacology journals, there were like letters to the editor saying, I've seen 2 cases of this, and we don't know what it is, and are these people psychotic? Or it sounds bizarre, but they're not psychotic. And I have seen no explanation for why this occurs, but it does. It's just bizarre. It's most likely to occur with these drugs. The reason being that they have a short half-life, so the more rapidly something is eliminated from your body, the more likely it is to have severe withdrawal symptoms. But it can really happen with any antidepressant except Prozac. And the reason Prozac is not on the list is because it takes about 6 weeks to completely eliminate Prozac, from the body. So if a person runs out of medication, then that is a good drug because if it takes 3 or 4 days to get a refill, their blood levels have hardly dropped at all. If they discontinue, whether the doctor says so or they do it on their own, it's got a built-in taper. Okay, so you don't have to gradually withdraw. Okay, maintenance phase. Okay. Now, it's been suggested pretty strongly that most people in the United States that take antidepressants don't have a good response. And it's because they don't have adequate trial, and an adequate trial is really determined by these 4 factors. One is the dose. And we're going to see from a study here in a few minutes, aggressive dosing really is a very good thing to do. I mean, if you're going to use drugs, you might as well use them correctly. And a lot of primary care doctors chronically underdose. Compliance is not very good. And part of this is side effect problems. Part of it is pessimism and hopelessness. But another part of it, too, is just forgetting to take your medicine or forgetting to refill it. And I mean, people don't have depression forget to take their medicines. You know? And let me just mention something here. Thank goodness. Now, almost all the drugs, antidepressants, can be taken once a day. If you take any drug that you take twice a day, then at least a third, if not a half, of people are never going to maintain that. And if you have to take it 3 times a day, it's even worse for somebody who's depressed. Now, where this is relevant is St. John's wort, which if you use it to treat major depression, you have to take it 3 times a day in divided doses. We'll talk more about that later on. And again, the research looks very good, but that's because some researchers paying somebody and making sure that they're taking the dose 3 times a day. The amount of time, you have to wait, enormous variability from one person to the next. We'll take a look at that. And then the blood levels and the medication. And there really is no advantage at all, clinical advantage, to measuring blood levels of the antidepressant, a laboratory test. But what this really refers to is whether or not you have some indication they may be a rapid or poor metabolizer. And if they're taking high-end doses, then it may be that they just need to go a little bit beyond the typical therapeutic range, and then they have a response. It would really be a shame if you had somebody who was a rapid metabolizer. Remember what that means? You take medication, you eliminate it real quickly, your blood levels are lower. Let's say somebody's been on the drug for 8 weeks. They're at what looks like the top dose, the recommended guidelines, and you say, well, it's not working, and you bail out. But if you just bumped it up 10 milligrams, it would kind of cross the threshold and they'd have a response. So a lot of people would say, a lot of psychiatrists would say, before we bail out, let's crank it. Let's push it up higher. And the only reason not to do that is if you run into side effects. And we're going to see that's a strategy used in this huge study that we're going to look at here in just a few minutes. Okay? But it's not done really hardly at all in primary care settings. But just, think about it. You've been on a drug for 6 weeks, 8 weeks, and then you switch to maybe a drug that isn't even going to work. So, just kind of, empirically, it turns out to be a good thing to do, but also kind of makes sense, too. Okay. Now, this is not rocket science, but it's somewhat helpful. And this assumes that the person's on the right drug, which is a big assumption. It assumes that they're taking the drug at adequate doses, or that they're actually taking the drug. And so there are people that are early responders. And early responders, if you carefully question them, or if you use depression rating scales, by the 2nd week, oftentimes you will start seeing a bit of improvement. Now, they aren't going to feel it so much, but it'll start showing up in terms of like a little bit more energy, for instance, that sort of thing. And these people oftentimes by 6 to 8 weeks have crossed the finish line. They're good responders. Okay. Late responders typically have one or more of these symptoms. They're very severe. They've had a history of having their first episode prior to the age of 18, and they've been depressed for more than 3 months. Now, walking in the door, if somebody's got these kind of symptoms, and this is really unfortunate because, these people are suffering even worse than many other people with depression, but you have to kind of factor in, we're going to need to hang in here longer before making a switch with these people, because many of them do ultimately have a good response, but it just takes them a little bit longer to get there. Okay. If you look at response, remission, complete recovery, partial response, and poor response. Now, what do you do with partial and poor responses? Here are the 3 main strategies. Optimization turns out to be probably the best first thing to do. As you stay on the drug, as long as they aren't overwhelmed with side effects, you keep them on the same drug, and you optimize by keeping on pushing the dose higher and staying with it longer. One of the biggest mistakes is bailing out before you had a really solid trial with that drug. Augmenting is you add a medication, and switching drug classes would be like switching from an SSRI to Wellbutrin, for instance. They're totally different neurotransmitter targets.